Good evening again, my friends from all over the world. We're streaming today at Saturday Congenital Heart Disease course at CEC. This is the seventh webinar. It will be discussing the right side obstructive congenital heart disease lesions. I have a very eminent speaker today, my dear friend and brother, Dr. Mahmoud Shahata, EACVI board certified congenital cardiology specialist at Aswan Heart Center. Mahmoud will be discussing the right side, the obstructive lesions in the form of a clinical scenario. I also have on board the moderators, Dr. Hatem Hosni, consultant of cardiac surgery at Aswan Heart Center, and Dr. Khalid Shams, lecturer of cardiology at Helwan University. I will pass the mic now to Dr. Mahmoud Shahata, and he will start streaming his lecture. So please go on, Dr. Mahmoud.
Thanks, Dr. Zahran. Good evening, everybody. Today we are going to talk about the right side obstructive congenital lesions. On the right side, we have seen this is the RV is formed from three parts. Part one is the sinus part, which is the inflow part, and part two is the body or the trabecular part or the apical part, and the part three is the outflow or the infundibular part. So we have different levels of obstruction all through this pathway from the inflow to outflow, even after the pulmonary valve here on the level of the BAs and the peripheral pulmonary arteries. By the way, the most common cyanotic congenital heart disease and obstructive lesions on the right side is the fallow. But this is a separate entity and they will be discussed in a separate webinar. So we are not talking about the fallow, but we cannot start talking about the right obstructive congenital lesions without nominating the fallow. So starting from the inflow, outflow, we have the tricuspid atresia stenosis, double chamber RV, the pulmonary stenosis from subvalvular or infundibular pulmonary stenosis, valvular pulmonary stenosis, supravalvular pulmonary stenosis, which may affect the main pulmonary artery or affecting the branch pulmonary arteries. And also one of the important obstructive lesions or the extreme form of the obstructive lesion on the right side is a pulmonary atresia, which may be pulmonary atresia in the context of the intact interventricular septum or pulmonary atresia with VSD. And also these are separate entities, will be discussed in a separate sessions. But we'll give some hint on the pulmonary atresia and the management of pulmonary circulation at the end of lecture. So we'll start with the common lesion, the valvular pulmonary stenosis, which is the fourth most common congenital heart disease. It represents around 8 to 10% of all patients with congenital heart disease. It ranges from 35 to 83 per 100,000 live births, which is around 5 to 7 per 10,000. Morphologically, there are three types of valve. The most common type, which is a dome-shaped valve with a fusion or underdeveloped commissures. And this valve has central opening, small, and according to the size of this central opening, it affects the severity of the obstruction. And it has mobile leaflets and the typical post-stenotic dilatation of the main pulmonary artery or the jet effect. The second type is the dysplastic pulmonary valve. We have here thickened and mucoid leaflets. Usually we have eccentric opening and poor mobility of the leaflets. And this type usually associated with tubular hypoplasia of the main pulmonary artery. And this type accounts for around 10% of the cases of the pulmonary valve stenosis. The third type was the rare type in the isolated valvular pulmonary stenosis is a unicuspid or bicuspid pulmonary valve, although this is very common in the cases of fallow. Depends on the severity, the hemodynamic effect of the valvular pulmonary stenosis. Like any obstructive lesion, we have pressure overload over the underlying ventricle. So initially starts with RV hypertrophy, which may later on affects the RV and the systolic pressure or in severe cases lead to severe TR with elevation of the RA pressure. And if you have an ASD or PFO, you may have also right to left shunt, and you may present by cyanosis. So it depends on the degree of the obstruction, the hemodynamic consequences of the valvular PS, is different into 3 categories: the mild, moderate, and severe pulmonary stenosis. And according to the degree of the stenosis, the physical signs also is different. So in mild cases, the cyanosis is usually absent. The jugular venous pressure is normal. Pericardial thrill by examination is absent. Right ventricular heave also absent. Systolic ejection click, it is present. Ejection systolic murmur, it is mid-systolic, and ejection in better. The second heart sound is almost normal. So it is irrelevant apart from the ejection systolic murmur and the systolic click in mild cases. In moderate cases, cyanosis also absent. Normal venous pressure. Maybe there is a precordial thrill and the right ventricular heave. Also, the systolic ejection click is only expiratory. And the ejection systolic murmur is long ejection systolic murmur and of grade 3/4/6. Second heart sound is wide and variable. And in severe cases, the cyanosis is possible, especially in case of intra-atrial septal defects or PFO. The jugular venous pressure is high with prominent A wave. Right ventricular heave is also pronounced. Systolic ejection click is absent. And the ejection systolic murmur is long. And the second heart sound is almost absent because it's very limited opening of the valve. Regarding the ECG, as a basic investigations, the mild valvular pulmonary stenosis, usually the ECG is normal regarding the electrical axis, the RS ratio, and the V1R amplitude, and the right atrial enlargement. In moderate valvular pulmonary stenosis, we have some degree of right axis deviation. The RS ratio is up to 4:1 in V1. V1R amplitude is around 10 to 20 millivolt, and right atrial enlargement is possible. In severe degree of valvular pulmonary stenosis, the axis is extreme right axis deviation. We have inverted RS ratio in left leads, and the V1R amplitude is more than 28 millivolt, and right atrial enlargement is almost present. Regarding the chest X-ray, and on the left side standstill image, we have the X-ray almost normal apart from prominent main pulmonary artery represented the post-stenotic dilatation. On the right side, we have a patient with severe or critical pulmonary stenosis. We have severe cardiomegaly of right ventricular pattern, and we have right atrial enlargement. Also, we have prominent MBA, and we have oligemic lung. By the way, the echo is the investigation of a choice in assessment of the many of congenital disease, but it is a standard tool in cases of valvular pulmonary stenosis. The normal pulmonary valve area from the continuity equation is calculated to be 2 centimeters square per meter square. And this is one of the parameters that's calculated to assess the degree of stenosis. So according to continuity equation, pulmonary valve area is calculated by multiplying the RVOT VTI using pulsed wave Doppler by 0.785 by RVOT diameter, and all this are divided by the pulmonary valve VTI using continuous wave. So the RVOT VTI is using pulsed wave, and the pulmonary valve using continuous wave. Also, echo is important for assessment of the pulmonary valve annulus and the morphology of the valve, as we mentioned, because we know that plastic valves are least to respond to balloon dilatation. So we have some information about the morphology of the valve, the post-stenotic dilatation, and the annulus size, because this is important for planning for intervention. So from the echo, also the degrees of pulmonary valve, the mild stenosis, pulmonary valve area is more than 1 centimeter square per meter square. The right ventricular systolic pressure is less than half systemic blood pressure. The peak pressure gradient across the valve is from 10 to 35 millimeter mercury. This is calculated from the Bernoulli equation, which means that the velocity across the pulmonary valve is less than 3 meters per second. In moderate stenosis, the pulmonary valve area is ranging from 0.5 to 1 centimeter square. The right ventricular systolic pressure is more than half systemic, but still less than 3/4 or 2/3 of the systemic blood pressure. The peak pressure gradient is from 36 to 64 millimeter mercury. The peak velocity across the pulmonary valve is from 3 to 4 meter per second. In the case of severe stenosis, we have the pulmonary valve area is less than 0.5 centimeter square per meter square. The right ventricular systolic pressure is more than 3/4 systemic blood pressure, or almost suprasystemic in case of critical pulmonary stenosis. The peak pressure gradient is more than 64, and the velocity across the pulmonary valve is more than 4 meter per second. I let the critical PS as a separate entity, which is usually presenting in the neonates. And this is because it is a critical situation with different management. These babies are usually presenting with severe cyanosis, and many of them are duct dependent circulation. So the critical PS defined to be when the RV is unable to maintain the systemic arterial saturation above 90% in the absence of a beta ductus arteriosus and in case of intact ventricular septum. Critical pulmonary stenosis leads that the RV is systemic or suprasystemic RV pressures. So this will end by severe tricuspid regurg, so lead to RV volume and the pressure overload, which may affect the function. If you have a PFO or ASD, which is common in the neonate, there is a right to left shunt across the PFO, so these babies are coming with severe cyanosis. To maintain adequate pulmonary blood flow, the BDA is still there. So these babies have LV volume overload from the BDA, and this LV is compressed also by the RV, so it has volume overload and pressure overload from the right side, which may end by poor biventricular function, and sometimes they present by cardiogenic shock. So we are going to discuss some cases to explain how the strategies of management of the pulmonary valve stenosis in different scenarios.
So thank you, Mahmoud. You're clearly defining here a wide spectrum for such a common lesion, the valvular pulmonary stenosis. So you talked about cases ranging from very mild stenosis with barely any clinical or findings on ECG and echo. And on the other hand, the other end of the spectrum is the severe pulmonary stenosis with high RV pressure. And actually, the really extreme end of the spectrum is patient presenting in a neonatal period in a really sick state with a critical pulmonary stenosis, and most of the blood on the right side actually shunting into the left side through a PFO. So this obviously does affect management. So would you kindly be describing the indications for intervention and timing for that, obviously on your cases? That would be nice to know. Before we passed this part, there was a question on our colleagues on YouTube asking about if you kindly show us how to define the pulmonary valve area on echo picture, if you can do that while you're describing echo.
Okay.
Thank you.
Thanks, Hadi. So I will back to the slide of the to define how to calculate the pulmonary valve area. So in this diagram.
So which view, Mahmoud, would you check for these?
I would prefer to get the parasternal short axis view. Try to identify the RVOT. If you don't have good chest windows, you can use the subcostal views with the left anterior oblique angulation.
So you try to get good alignment so that you're aligned to the flow into the pulmonary valve.
Yes. So you try to be parallel to the flow with the cursor as much as you can. So making the angle of the Doppler is almost 0 to get a good alignment and a good gradient. Then you measure the RVUT diameter, which is the red in this view. And you use a pulsed wave Doppler below the pulmonary valve to get the RVUT VTI. And to use continuous wave across the whole RVUT and the pulmonary valve to get the VTI across the pulmonary valve. And using this equation by multiplying the RVUT VTI by pulsed wave Doppler by 0.785, which is a constant in the equation. It has many equations to get this conclusion, but I mean this to be easy. And even in most of machines, the protocol of the echo will calculate this area directly if you get these dimensions and go to pulmonary valve area. So it will get you to fill just the RVUT VTI, RVUT diameter, and the pulmonary valve VTI, and it will calculate it automatically.
And also, for colleagues like me who are not very good at echo, so simply the continuity equation is that the amount of flow in the RVUT should be the same.
Should be equal to the amount of flow
through the valve itself, and the flow is the area times the velocity. So if you get the area of the RVUT and the velocity of blood there, and then you know the velocity of the blood across the valve, then you get the valve area. This is very simplified for those who like me.
So we can change the seats now, and you can come to present. I wouldn't go in details in the in the echo, but this is simplified. I know also that
do you use this method frequently for the pulmonary valve?
No, most of people also depends on the gradient only across the pulmonary valve, and the RV systolic pressure can be calculated if you have a good wave from the TR, and the velocity as well. It's related to the pressure gradient, so you can get the other 3 parameters from the echo easily. And if you have the pulmonary valve area protocol, it can confirm it in the cases which between grade the mild to moderate or something, because in mild cases you will not go for intervention. In moderate cases, some people do intervention, some wait for gradient more than 60. So if you have a gray zone, you can use further parameters to quantify the degree of stenosis. But simply, most of people use the gradient across the pulmonary valve, as it is mentioned, from 10 to 35 it's mild, from 36 to 64 it's moderate, above 64 it is severe, and this is a peak, and this is different than in the aortic valve, because people, the classification in the aortic valve degree of stenosis depends on the mean, not the
mean pressure on the aortic valve,
not the peak.
Clean the house.
So is it clear now?
Yes,
or,
thank you.
Okay.
Yeah.
So
we had another question. Do you think the continuity equation on the pulmonary valve is accurate? So you mentioned that it's one of the parameters. You mostly use other parameters, but how accurate is it?
If you get a good images, it is accurate. But I know that most of people have difficulties with the RVUT and the calculation, and if you have multiple levels of obstruction also, it will be affected. So continuity equation can be applied also if you have only single level of obstruction, like valvular PS, and you have a good images for the RVUT, because RVUT can be measured from parasternal long axis with anterior angulation, can be measured from the subcostal views. But you need to measure all these parameters in single view. So if you can do that from the parasternal short axis or from parasternal long axis with good angulation, it will be great. And as we mentioned, that this also for quantification, if you have a gray zone degree of stenosis and you need to plan for intervention.
May I interrupt you?
Okay.
Hello, everyone. This is Khaled Shams.
Welcome, Khaled.
Welcome, Mahmoud. I have a comment about the accuracy of the continuity equation. Clearly, Haitham, we don't have a lot of data about the accuracy of the continuity equation. The continuity equation is extremely studied for accuracy in assessing the aortic valve area. However, in pulmonary valve area, we don't have a correlation to the CT. So we are not extremely sure about the accuracy of the continuity equation. And as Mahmoud mentioned, it's a bothersome in calculating if you don't have the software on the machine. Nowadays, all the machines have the software for calculating the pulmonary valve area. You just need to measure the RVOT VTI, the pulmonary valve VTI, and the RVOT diameter, and you will get the pulmonary valve area spontaneously. So you don't need to be anxious about the equation and how should I calculate it. It's done automatically by the machines. The second issue, as Mahmoud mentioned, indeed, we don't routinely do the continuity equation for measuring the pulmonary valve area. We usually depend on the pressure gradient, the peak pressure gradient, and we rarely have an malalignment with the Doppler flow and the continuous wave Doppler and the flow. So we rarely get an inaccurate gradients.
So that's clear now to everybody that simply we use the gradients. But in case of doubt of degree of stenosis, or if you want to plan for further intervention or for academic purpose or something like that, you can use the continuity equation from the echo machine.
Yes,
so
sure.
now we will go to the case number 1. We have a 1-year-old male infant accidentally discovered to have murmur on routine pediatric examination, and then referred for echo. On examination, from the history, he is asymptomatic with only anxious about the murmur. So by examination, he have only ejection systolic murmur grade 2/6 over upper left sternal border. His ECG and chest X-ray were normal, and this his echo. I just get the view of interest for the diagnosis. This is a parasternal short axis view. Here we have the RA, we have the tricuspid valve, the RV inflow, and this is the RV outflow. And this is the pulmonary valve level. And by the way, this is the aorta and short axis. We get from the echo that there is a liaising or flow acceleration across the pulmonary valve. And this is getting a gradient of 30. It is almost less than 30 something. It's less than 3 meters regarding the velocity. What do you think, Khaled, about the management for this case? It's an isolated mild valvular pulmonary stenosis in a 1-year-old male infant.
As you just mentioned, Mahmoud, we always have a correlation between the symptoms, the basic findings in the investigations, and the findings in the echo. Here, the baby is completely asymptomatic, and his ECG and chest X-ray are correlating with being asymptomatic, which was confirmed by echo that we have an mild pulmonary valve stenosis. It's purely valvular without any association, without infundibular or supravalvular stenosis, and the gradient denotes mild valvular PS. We don't have any indication for intervention. The baby is completely asymptomatic. we don't have an RVH, so we don't have an RV hypertrophy or RV load from the pulmonary stenosis. I think all the findings are correlating with being mild valvular PS. And by experience, we have seen a lot of patients with mild valvular PS who usually tolerate this pulmonary stenosis for a long period of time, and they don't need any intervention on the long term. So I think reassurance for the parents is more than enough.
If the, I mean, and your recommendation about the prophylaxis against infective endocarditis, what do you think?
I think this is a big dilemma, and we have agreed in the previous webinars that the approach in our country is different from the European and USA. The guidelines nowadays are not recommending prophylaxis against infective endocarditis for mild valvular PS. But I think that in our country and having some sort of let's say
orodental hygiene or
orodental hygiene, yes, and working in ORs with whatever he's doing non-cardiac surgery, and we don't have an idea about how much this system is
infection
clear
control
and sterile.
competence.
Yes. So I usually recommend prophylaxis against infective endocarditis for those children.
Okay. How would you recommend follow-up for such patients? So do you charge him for follow-up and reassure him, or do you follow him up regularly?
No.
How often? What investigation?
Yes, we know that from the studies, that the long-term studies of natural history of the mild valvular PS, it usually continue like for 10 years without changes in the gradient. But being an obstructive lesion, and most of the obstructive lesions are progressive, so we don't know that. I mean, I know most of the patient will continue to follow without changing the gradient or the degree of stenosis, but at least he should have follow-up at 1 year interval, like for 5 years, and then if it continue to have the same gradient and same degree of stenosis, he can increase interval to 2 to 3 years interval. But I would like to comment here on that this baby is presenting at age of 1 year. We have a different strategy if we have this baby presenting at age of 1 or 2 months in the neonatal period. Because we know these babies are coming with a bit elevated pulmonary vascular resistance and pulmonary arterial pressure. So sometimes these gradients are misleading as a degree of stenosis, and you need to have a follow-up shortly after the neonatal period at age of 2 to 3 months, and then to check every 6 months till the age of infancy. But then you can continue with the same protocol as early childhood or late childhood with 1 year interval.
I see. So early on, because of the pulmonary hypertension of the newborn, the gradient might not be high because RV pressure is high, but also PA pressure is high, so the difference is not high. So you recommend further follow-up after the pulmonary vascular resistance has dropped. That's good.
Thanks, Mahmoud, for stressing on this tricky clinical scenario. I do agree with you that these papers can deteriorate very rapidly, especially once the pulmonary vascular resistance drops. We get a severe pulmonary stenosis. I myself usually follow up those patients meticulously, maybe every 2 weeks or every 1 month. And I want to highlight a very important point in those papers. We should always depend on the 2D images regardless of the pressure gradient. If you have 2D image which denotes severely stenotic pulmonary valve, and you are getting a low pressure gradient, you should always be meticulous in assessing those data very frequently. And another more important point is the function of the RV. If the function of the RV is impaired, you will get a tricky low pressure gradient across the pulmonary valve, which does not correlate with the severity of the stenosis. I have one more comment about this child, the 1-year child with mild valvular PS. A frequently asked question from the parents in all their papers is usually can he participate in sports or not? We have the information that severe pulmonary stenosis is a contraindication for participation in competitive
activity
sports.
and competitive sports.
Yes, in competitive sports. Otherwise, those children can participate in sports provided that the pressure gradient is low.
Thanks, Khaled, for this important comment. Really, a lot of the parents are asking about the practicing sports, and the recommendation for the cases with mild valvular pulmonary stenosis or the patient after intervention having mild gradient of valvular pulmonary stenosis should participate in every type of sport like normal individuals, and no restrictions. In case of moderate or severe stenosis, there is some restrictions regarding the sternus activity or the high intensity sports. So we'll go to the next case. So 6-month-old male infant, due to delayed milestones, he sought medical advice and pediatric consultation, and during examination, the pediatrician discovered to have a harsh murmur and referred for echo. On examination, the baby is underbuilt. He's 4.8 kilograms, no neck support, poor mother contact, ejection systolic murmur grade 4/6 over the upper left sternal border. His ECG shows RVH and right atrial right axis deviation, and his chest X-ray shows cardiomegaly and the prominent main pulmonary artery. This is echo. Again, the parasternal short axis, this is a high parasternal short axis, shows a doomed thickened pulmonary valve with good mobility. We have appreciate here the post-stenotic dilatation affecting the main pulmonary artery and the proximal LBA. This is by color Doppler interrogation. Can see the jet is hitting towards the left, the LBA more than the right. And by continuous wave Doppler, we get a gradient of 60-65. It's almost 4 meters per second velocity. So what do you think about the management, Khalid, in this case?
I think you managed this case very well.
Sorry, I'm rushed to the
no,
next
never
slide.
mind, never mind. I think this is the other spectrum of the valvular PS. We are facing a child with severe valvular PS, and as I just mentioned in the previous case, there is always a correlation between symptoms, the investigations, and the management. From the history, this baby is asymptomatic. His ECG showed an RVH and right atrial dilatation, correlating with just X-ray that we have cardiomegaly due to the right ventricular hypertrophy and a prominent main pulmonary artery. And as you just mentioned in the echo, its explanation is the post-stenotic dilatation from the severe valvular PS. Thank you so much for marvelous echocardiographic images, which I'm really enjoying. As a pulmonary valve in the previous image, in the 2D image, looks a second with doming and restricted mobility of the tips, and the post-stenotic dilatation is clear, correlating with the pressure gradient, which is high for severe pulmonary stenosis. Unfortunately, we don't have a lot of options. I know Haytham would be anxious about saying this, but it's clear and straightforward. We should go for percutaneous pulmonary valvuloplasty.
Okay.
So I think the most important question in this case is not discussing the case itself. I want to discuss another important issue, and I want to hear from you. I know that you have a very good experience in interventions. It's about the technique and the balloon dilatation.
Khalid, would you please raise your voice, because I'm getting comments from YouTube, they cannot hear you properly.
Okay. I want to hear from you about the management. I know that you have a very good experience in this field. We do have different types of balloons. So which balloon for which lesion, and about the sizing of the balloon. How do you choose the size of your balloon?
Okay. So initially from the echo, as we mentioned before, if you're planning for intervention, you would like to get some data more than the gradient. So from this image, you can get the measurements of the pulmonary valve alignment and the systolic frame with the dooming of the valve. As most of the interventions nowadays are ballooning these valves using a ratio of a balloon to annulus ratio of 1.2 to 1.4, and not, I mean, in the old days they are using bigger ratios, but this ends with a more moderate regurg after balloon dilatation. So we stick to the least effective balloon size, starting from 1.2 to 1.4. So in this case, it's a moderate to severe stenosis gradient of 60. The valve mobility is okay. There is no regurg. I would like to start with a 1.2 ratio in the balloon sizing. This regarding the size. I also confirm the size with using the angiography. So we start injecting in the lateral projection. This is, we use an in-the-hole catheter here, but because of measuring the pressure gradients. And then after measuring the BA to RV gradient, or at least the RV pressure gradient of if this valve is difficult to cross, so we can measure just the RV pressure gradient initially, and do the angiogram, and then get the measurements of the annulus. And if this, I mean, a good type of valve, the dome-shaped valve. So we are using in we try in the children to use the low-profile balloon. So we'll get the low-profile balloon. Or low profile, I mean that it goes over a smaller sheath, so you cannot hurt the femoral venous axis, and also it has a short shoulders. I mean, like this balloon, and also it can open and I mean inflate and deflate easily. So we are usually using low profile balloons like the Taishak 2 in these valves. And there is another types, I mean another trade names for a different balloons, but the Taishak is a most common one we are using in the valvular pulmonary stenosis because of its low profile and Also, it is a low pressure balloon because you want to just open the commissure in this valve and not cause any injury to the arterial wall or the RVOT or getting out with a severe regurg. So Khalid, your comments.
We usually use low pressure balloons. The low pressure balloons, as you just mentioned, have two important features. The first is a lower profile than the high pressure balloons with a less incidence of injury to the RVOT and the pulmonary valve. The second most important advantage is that we need a smaller size of sheaths, so a lesser extent of femoral venous access complications. About the sizing of the balloon, we choose a balloon size ratio to the pulmonary valve annulus of 1.2 to 1.4. So the balloon size is 1.2 to 1.4 to the size of the pulmonary valve annulus.
This is a straightforward case. After the angiography, we're choosing the size.
May I have another question? You mentioned some of the complications while talking about the balloons. What are the most common complications we usually face while doing balloon dilatation of the pulmonary valve?
You may get a lot of complications, but the most common, if you go beyond the burst pressure of the balloon, each balloon has two numbers for pressures, the nominal pressure and the burst pressure. So if you go beyond the burst pressure of the balloon, you will end with the rupture of these balloons because it's of low profile and low pressures. Doing a balloon valvuloplasty is a simple procedure. Retrieving a ruptured balloon is another procedure. Yeah. Because especially there is a lot of types of rupture. If it's ruptured horizontally or vertically, it's different. If you have all the pieces of the balloon connected or not, so a lot of complications you don't want to go through with this simple procedure. So as Khalid mentioned, using low profile balloon, low pressure balloon, also stick to the number and the pressure. And even if you want to use another balloon, you can get a medium pressure balloon rather than inflating the balloon beyond the burst pressure.
I think rupture of the balloon is the nightmare of the cast lab while doing balloon pulmonary valvuloplasty. The most common complications, as we just mentioned, is the vascular access complications. As Dr. Mahmoud mentioned, the injury to the RVOT while either manipulating your catheter or manipulating your stiff wire and balloon. And please don't ever oversize your balloon to the side of the annulus because, as Mahmoud mentioned, having and severe pulmonary regurg is one of the worst complications of PPV that you usually don't like it to happen.
So thank you. I have some questions here and some questions from our colleagues. So what is the suitable body weight for such interventions? So is there a body weight that you say below that is too small, or do you do that with any unit?
Nowadays, thanks to the inventory and the inventions of the very low pressure balloons, we have, variable types and variable in different sizes of a very low pressure balloons that can go through 3.5 French sheath. So you can do in whatever the age, but the main the main issue here, if you have a moderate valvular pulmonary stenosis and you have a small baby of 15 days or 1 month old, so it's better to let him grow up and do this procedure in a better shape of the patient with, I mean, good access and easy access. Because having also an access in a 2 kilogram neonate is not a luxury, and sometimes we are obligated to do that in critical cases or certain cases. But if you have a patient with a moderate to severe pulmonary valve stenosis, while the patient doesn't have severe symptoms and can tolerate the PS till grow up a bit, it's better.
Yeah, I see. That's reasonable. Another question. How do you assess the result? So do you routinely measure RV pressure post-dilatation, and what are the usual findings that you get?
This is a very good question.
Yeah. So as we mentioned, initially we measure the RV pressure pre-dilatation. Sometimes, and also it's better to measure the BA pressure and know the gradient before dilatation, because some cases have different level of stenosis. You may have peripheral pulmonary stenosis and you don't know. So if you know also only the RV pressure, this resembles the whole pressure load across the whole pulmonary circulation, not across the valve. So if you have different level of obstruction, it's better to measure the gradient across the valve, which is the I mean area of intervention in this case. This initially. Then after dilatation, you will go with the caster across the wire to the distal branch pulmonary arteries, and you do pull back pressure from the branch pulmonary to the MBA, and from the MBA to the infundibulum, and from the infundibulum to the RV, to get the gradient across the whole RVOT in a retrograde fashion. And the results to say that this is a successful balloon pulmonary valvuloplasty depends on two things. Some people are doing angiography after balloon dilatation to check the opening and the morphology of the valve, and if there is a dynamic obstruction at the RVOT. And some people only satisfied with the echo and I mean achieve this information through the echo. The second thing is to measure the RV BA gradient, and the target is to have an RV pressure almost below the fifth of systemic pressure. So you need to have an RV pressure less than 0.5 systemic blood pressure. So if you have a systemic blood pressure of 100/50 in this child, so you need to have an RV less than 50 millimeter mercury at least. It's better to have it 30, but I mean to say that this is successful if you get if the RV pressure before dilatation. Yeah, this is the criteria of success.
Okay, and how Khalid mentioned pulmonary regurg
as a complication.
So how frequent do you get that, and is there any predictor? Khalid talked about balloon size, but is there any other predictors or not?
The other predictors, the morphology of the valve itself and the degree of regurg before dilatation. Because we have in the dysplastic valves, we have sometimes the valves with severe stenosis and moderate regurg from before balloon dilatation. And having an RV pressure in the cath lab of 100 or even sometimes suprasystemic. So you are expecting these cases to have more regurg after dilatation.
Yeah.
This is one factor. The other factor, as Khaled mentioned, the balloon size itself, and the morphology of the valve. Some valves also dysplastic without regurg, but they are thickened and bicuspid or mucoid leaflets, especially in syndromic patients. So you wouldn't expect the degree of regurg after dilatation. Anyway, you need to unload this ventricle from severe pressure overload.
I see. And is it a frequent finding? I mean, is it usual to get like mild to moderate regurg, or is that a rare finding?
It's frequently to see mild regurg after balloon dilatation or mild.
Probably very well tolerated.
Yeah. Okay.
I have one more comment about the success of the procedure. As Mahmoud mentioned, the bull pack pressure gradient is the most accurate method to assess the pressure gradient across every segment of the RV outflow. Assessing the pressure gradient across the peripheral pulmonaries, across the pulmonary valve, and across the RVOT, because one of the most common it's not really a complication, but one of the most common sin procedures after the procedure is the infundibular reaction from the balloon dilatation, which usually overestimates the RV pressure. So you have always to check that you don't have a severe infundibular reaction, which will give a false impression of a high RV pressure. And the most approved criteria for success are drop in the RV pressure of 50% compared to the pressure gradient measured before the procedure, or drop in the RV pressure to less than 30 millimeter mercury. And this is a very important point, especially when you are dealing with babies with critical pulmonary stenosis, and when we have an pressure gradients that's very high. If you can say, for an example, if you have a pressure gradient of 120 millimeter mercury, you don't need to get at the end of the procedure an RV pressure gradient which is 30 millimeter mercury, because definitely if you get this pressure gradient, you will have on the expense and a significant pulmonary regurgitation. But a drop of the pressure gradient from 120 to 50 millimeter mercury is a success.
Okay. Being a surgeon, I want to ask a question. When would you consider a case not suitable for balloon, or would you go ahead and do balloon for any valvular pulmonary stenosis? So when would you refer that for surgery?
Actually, we don't like to refer PS to surgeons.
That was a trick question, yeah.
Okay. Going to the third case, we have 15 days old female baby presents to ER with severe cyanosis. On pediatric examination and discovered to have soft systolic murmur. Oxygen saturation was 55 with no response to hyperoxia test or minimal response. So admitted on prostaglandin infusion and referred to our center for evaluation. On examination, he is 3 kilogram, oxygen saturation 80%, soft ejection systolic murmur grade 2/6 over upper left sternal border. Her ECG shows sinus tachycardia, RVH and right axis deviation. Her chest X-ray shows cardiomegaly and oligemic lung. When we do the echo from the subcostal views, we can see dilated right atrium, a stretched BFO that's shunting dominantly right to left, and also we can see the jet of the tricuspid regurg here. So going to the fourth chamber view, we have seen the RV is heavily trabeculated, markedly hypertrophied, and we have seen the severe tricuspid regurg, and the RV function, systolic function, is almost affected. Going to the parasternal short axis views, we can see systolic dooming of the pulmonary valve, which is almost immobile, with a vein hole opening with this jet. We can see also the flow of the BDA after starting the prostaglandin in this view. So getting a gradient across the valve from the best view was from the subcostal, is getting around 110 in 15 days old neonate. And go to the suprasternal views or hypersternal view, to the ductal view, to assess the duct patency. Still the BDA is having a restrictive flow. This is a descending aorta, this is a left pulmonary artery, this is a BDA, this is aortic end, and this is a pulmonary end. And this is a continuous wave Doppler across the BDA showing a gradient of 56, which means that the PA pressure is low and the gradient in the BDA is restricted. So what do you think, Khaled, about the management?
You are showing the extreme form of valvular PS, one of the most critical conditions that every interventional cardiologist will face in his practice. Critical PS is one of the worst clinical scenarios you will see. As you mentioned, a baby who is cyanotic, sometimes we are dependent on the ductus. We usually use to maintain ductal flow, to maintain circulation using prostaglandins. You are facing a child who is, or a baby who is usually 2 or 3 kilograms. So are expecting vascular access complications, as we just mentioned. Having a dysplastic pulmonary valve is completely different from dealing with a pulmonary valve who is stenotic but with a normal morphology. The dysplastic pulmonary valve response to balloon dilatation is always unpredictable. Either you will go out with residual stenosis, or as you mentioned in the previous case, you will go out with a significant pulmonary regurgitation. The management is for sure percutaneous. The sooner the better. And I usually don't like to face those cases, and until now I get always stressed while doing percutaneous balloon dilatation for those critical cases.
As you mentioned, Khaled, this baby in a critical situation, and first of all, we need to maintain his pulmonary circulation. So we need to stabilize the patient at the ICU with the fluid management and the prostaglandin infusion till preparing the cath lab for intervention and getting the whole team on table. I would like also to include the surgeons in the management of these cases, because some of these cases have, this case has a pure valvular pulmonary stenosis, but some cases having a severe subvalvular and valvular. So while trying to open this valve with a balloon, you will end up with an obstructed RVOT with severe obstruction, which initially looks stented with distal stenosis at the valve. And then in this case, we after stabilization, we will go to the cath lab. So here is the management of this case. We started as usual with injection at the sometimes AB cranial and the lateral. Depends on the morphology that will show us better visualization. In this case, we continue the case in the AB cranial. So we initially continue the procedure while using a prostaglandin to maintain the cardiac output. So we start with a very low profile balloon, sometimes coronary balloons with 2 millimeters to get a track across coronary wire even, and then go to a low profile balloon also, which can be advanced across the coronary wires just to open this lesion. And here is a final angiogram. As we mentioned, we have dynamic subvalvular component in this angiogram, which will continue sometimes for a while, needs the fluid management, or some people will give beta blockers for these cases. What do you expect? What do you expect to stop the prostaglandin and start to extubate this patient and send him back?
We usually have an marked improvement in the saturation once the pulmonary valve is dilated. The problem is in the RV. In those papers, the RV is usually very stiff and cannot tolerate the circulation very well. Maintaining prostaglandin for 1 or 2 days post dilatation in some papers is mandatory to help in circulation and passing blood flow to the pulmonary circulation. Although this is not common and this is not the routine, but sometimes we are obligated to maintain those papers on ventilation and prostaglandin for a few hours after the procedure.
Yes. And if this baby had an impaired systolic function pre-procedure and after dilatation, seeing the RV still have some stunning or impaired function, would you recommend to start some inotropes?
Inodilators would be very helpful, and we should always keep in mind that one of the worst complications in those papers after balloon dilatation, even when the baby is still on table, is a suicidal RV. And for all, suicidal RV is one of the worst complications you would face while dilating a pulmonary valve. Simply, it is a sudden collapse of the RV after balloon dilatation, resulting in a cardiac arrest, and usually suicidal RV is unrecoverable, and usually those papers pass away. So we should always keep in mind this complication, and we should always be ready for this complication. And the avoidance of suicidal RV is very simple, by just hydration of the baby pre-procedural could help in preventing suicidal RV. And as you, Mahmoud, showed elegantly, that one of the precautions that should be done to avoid suicidal RV is what we call stepwise gradual balloon dilatation of the pulmonary valve. We usually undersize the balloon and we dilate the pulmonary valve very mildly at first to enable some blood flow to go to the pulmonary circulation, and then using the proper balloon size to the pulmonary valve angles.
Okay.
And back to Hatem question. Hatem just asked the question about when do you refer a child to surgery, and I just remembered the case while discussing this case, vascular access complications. One day I was obligated to refer a baby with a critical BS to surgery, because the baby was extremely desaturated. We don't have a PDA at the time, and even we have a congenital anomaly in the femoral veins. Actually, we didn't have, this baby didn't have a well-formed femoral vein, so we couldn't get an access, a simple access to do the procedure, and we were obligated to refer this baby to surgery.
just to answer your question, Haitham, pure valvular pulmonary stenosis is for percutaneous intervention. When you have an other association like a double chambered RV with the valvular PS or severe muscle band causing infundibular valvular PS, or you have sometimes you have a valvular and supravalvular pulmonary stenosis with the main pulmonary artery and tube-like. We don't have a luxury for intervention for those babies, unfortunately.
Thank you, Khaled. I think it is a bit tricky to accurately define before intervention if this is a pure valvular or if it is a supravalvular element or infundibular element, because sometimes, as you say, you have both valvular and subvalvular, but since the RV pressure is very high, so the infundibular is stretched open, and once you relieve the valvular element, the subvalve collapses. So do you or Mahmoud have any tricks defining if that is a supravalvular or infundibular? Because I believe then the results of the balloon might not be ideal. Or what do you think?
I think if we have the fix, usually with severe forms of valvular pulmonary stenosis, we have some degree of hypertrophy of the infundibulum, like any part of the RV. So if you have a hypertrophied, muscular infundibulum hypertrophied, not a fixed subvalvular band like Khaled said, or muscle band, or fibrous band below the valve, or attached to the leaflets of the valve, limiting its mobility. So having just tubular hypertrophy of the infundibulum with any degree of valvular pulmonary stenosis is present. So this can be managed by balloon dilatation unless you have a fixed infundibular obstruction. And also regarding the supravalvular element, if you have just a ridge at the sinotubular junction, which is attached sometimes to the or limiting the valve mobility, you may start with a balloon dilatation to open up the valve and relieve some of the gradient and see how is the results, because sometimes it's difficult, as you mentioned, Hatem, to identify what is a dominant lesion. Unless you have a tubular hypoplasia of the MBA or distal obstruction at the branches or kink at one of the branches, you should go first with balloon dilatation. Otherwise, in the case of tubular hypoplasia of the MBA, it's better to go for surgery, because anyway, the distal obstruction will not relieve the RV pressure even if you open up the valve.
I see, thank you.
Also, last comment here regarding the axis. If this baby comes early, you have also still have the option of the umbilical venous axis. Some people also of the BDA is still open. They try to go if you miss the vein and you have the access to the artery, you can go through the BDA and try, although it is very difficult. But some people try it like that to open the valve in very difficult situation. Some people also do it from the jugular axis. If you have abnormal anomalies or some babies in the NICUs having a DVT after a catheter in the femoral veins or puncturing for blood gases. So you can use the jugular venous axis for ballooning the valve. I know it's the control from the jugular axis is difficult than the femoral, but still an option for balloon dilatation. Try to do some effort not to refer the patient to the surgeon. Okay. So
there's another question about would you further explain what happens in the suicidal RV?
Khaled can answer the question.
Simply because we have a very high pressure gradient inside the RV, So once you open the pulmonary valve, consider, if we can give an example, consider the RV like a balloon who is inflated with air and closed. When you puncture the balloon, what happens to balloon?
Deflates.
The balloon deflates suddenly and goes away. This is typically what happens in suicidal RV. Once you open the pulmonary valve, the blood flow goes very rapidly to the pulmonary circulation with sudden collapse of the RV. And as we just mentioned, the RV in those papers is usually very stiff and hypertrophied. It's extremely hypertrophied and very stiff that it could not tolerate to be inflated again with the forward flow from the tricuspid valve. So the RV become collapsed on itself and remains collapsed like this for a few seconds with cardiac arrest, and it's very difficult to get activity again.
So in other words, it is an acute severe attack of RV diastolic dysfunction, preventing blood flow into the RV, although now the RV is not has no fixed obstruction, but because of the severe diastolic dysfunction, it does not allow blood to go in, with severe decrease in cardiac output, and so patients lose output because of that. And so, as you said, maintaining hydration, giving volume, and maintaining prostin can help maintain cardiac output and saturation during this period.
Yes, exactly.
Yes, exactly. And also the gradual or stepping balloon dilatation, getting the RV gradually relieved from
Gradual
the obstruction.
opening of the pulmonary valve. Yeah, this is a frequent problem that we see, as you say, in the valvular pulmonary stenosis, the critical PS, and patients with pulmonary atresia intact septum when you open the pathway, and to a much lesser degree in the after tetralogy of Fallot repair.
Yeah. So to conclude the indication, timing, and management options for the babies, we have the last Indian guidelines 2019. Valvular pulmonic stenosis, immediate intervention required for newborn with severe PS who are duct dependent, class 1. Infants, children, or adults with with right ventricular dysfunction due to severe pulmonary stenosis, regardless of the valve gradient, as Khalid mentioned, because of the impaired function or affected function. This class 1 also immediate intervention. For elective balloon dilatation, people who are asymptomatic or symptomatic patient with valvular pulmonary stenosis having a weak instantaneous gradient by echo Doppler more than 64, class 1. Neonates and infant with any degree of PS who have mild hypoxia due to mild hypoplasia of the RV, even if right ventricular function is normal, it's class 2A. And this is the target of the balloon dilatation in this scenario is usually to invest in this hypoplastic RV to allow inflow and outflow, a good outflow, so might help the growth of the RV, especially in the neonates and infants. And the third category of elective balloon dilatation is a patient with valvular pulmonic stenosis due to this plastic valve who meet the above criteria. That's class 2A. The mode of intervention, balloon dilatation class 1, surgical intervention reserved only for, and this class 1 only, also in subvalvular or supravalvular pulmonary stenosis with indication same as in valvular stenosis, I mean the gradient. Noonan syndrome, dysplastic valve with hypoplastic annulus, because even if those babies has dysplastic valve with a small annulus, even if you dilate the valve, still there is a mechanical obstruction because of the small annulus. And by the way, the failed balloon dilatation cases due to cause or another also is a class 1 indication for surgical intervention. This is a summary of complication of balloon pulmonary dilatation. As Khalid mentioned, the axis, hemorrhage from the axis point. If you, I mean, crossing from the vein to the artery, or if you injured the artery while getting the axis, catheter or wire manipulation may lead to arrhythmia and hypotension because some babies get into SVT or heart block. or atrial arrhythmias while manipulating with wires, embolic complication, balloon inflation. You have the pulmonary arterial tear if you get an oversized balloon or high pressure balloon for a simple valvular pulmonary stenosis. Tricuspid valve papillary muscle rupture, and this happens when you also get a long balloon for a small baby. So this balloon, if you cannot control it well during inflation, it might jump proximally towards the tricuspid valve, injuring the papillary muscle or causing rupture. And we have seen few patients with flail tricuspid valve after balloon dilatation with severe regurg and need surgery for this valve also. Sometimes also you can entangle through the tricuspid chordae if you are using the wire without looping or going to the tricuspid with a Terumo wire or something like that. So there is a lot of mechanisms to do injury for tricuspid valve through balloon dilatation of the pulmonary valve. Cardiac perforation and tamponade, if you go with a wire to a wrong place, or if you use an oversized balloon causing a tear or rupture in the RVOT or the pulmonary valve. After inflation, severe reactive infundibular stenosis, as Khalid mentioned, from the from the reactive infundibular stenosis that can overcome over time to a suicidal RV. The late complication is a femoral venous stenosis or occlusion, recurrence of pulmonary stenosis, pulmonary incompetence.
Thank you so much, Mahmoud, for an elegant talk about valvular PS with a variety of cases that are really brainstorming. And I think it's clear now the type of management, either it is balloon dilatation. Okay, sure. I think it's clear. I think it's clear now as the difference between the management, whether it is balloon dilatation or surgical intervention. As you just mentioned, balloon dilatation is the routine management. We usually preserve a surgical intervention when we have an association with the valvular PS, either it is subvalvular or supravalvular, in severely dysplastic pulmonary valve, when we are expecting a higher degree of damage to the pulmonary valve. I think we have a question from a few minutes on the chat about the dysplastic pulmonary valve, one of the worst complications, and the unexpected is the pulmonary regurgitation, post balloon dilatation of dysplastic pulmonary valve. When you have an extremely dysplastic and dysmorphic pulmonary valve, surgical intervention would be better. Those are the indications for surgical intervention. We don't say that surgical intervention has no rule. Surgical intervention still has a rule, although it is limited, but surgeons are always there, and they are our backbone. We should refer patients with extreme anomalies to surgery, and do not sacrifice your baby, because there are a lot of complications from the balloon dilatation that could happen. As Dr. Mahmoud mentioned, a lot of complications could happen, although they could be avoided, but also complications do happen. Thank you so much, Mahmoud.
Okay. So back to our lecture, we have the other congenital obstructive lesion on the right side. So we'll start anatomically again. So as we mentioned, starting from the tricuspid valve, we have the tricuspid valve stenosis, hypoplasia or atresia. Isolated congenital tricuspid valve stenosis is very, very rare and usually is acquired as a part of rheumatic heart disease. Mostly it is part of a complex congenital heart disease Stenosis is the main presentation, especially if you have the PF4 ASD. I'm talking about congenital group of patients. If you have the PF4 ASD, still continue to maintain the cardiac output with mandatory right to left shunt, or even in some cases with tricuspid atresia. I mean, I know it is rare to have restrictive VFO in these cases, but we face some patients with tricuspid hypoplasia or atresia with restrictive VFO and need to be, need to have atrial septostomy by balloon. Also, because of the flow theory during embryological life, and we have a problem at the tricuspid valve, so the flow through the RV and the RVOT are affected, and the development also usually affected. Management usually follow the univentricular pathway, either 1.5 ventricle or univentricular pathway, because if we get a tricuspid atresia or hypoplasia, usually the RV is underdeveloped and cannot carry the pulmonary circulation, so we need to go for further management in the univentricular pathway, and this is a separate webinar, will be discussed later in details. This is an example. 4-chamber view shows a baby with, sorry, the video is not working fine, but this is a zoomed in view with a color interrogation for the same baby. We have seen here that tricuspid valve is very, very small and hyplastic, and if you put it in the Z score, it was -4 in comparison to the mitral valve. This is just an example to show you how to see the morphology of the tricuspid valve and how it looks in these cases. The second lesion is what's called the double chamber RV. And the double chamber RV is a different entity than double outlet RV, because some people mix these entities, and double chamber RV is an obstructive lesion. It is etiologically happened due to apparent hypertrophied muscle bands or anomalous muscle bands. It is rather than the moderator band or the normal bands of the RV morphology. This anomalous band divides the RV cavity into proximal high pressure chamber, which is the sinus part or the inflow part, and a distal low pressure chamber, which is the outflow part. The etiology is unknown, although there is a lot of theories trying to explain the development of the DCRV. One of them is arrested incorporation of the primitive bulbous cords into the RV body. Some also explaining because it's a frequent association with the VSD. So it's explained by the jet of the VSD itself, which will induce hypertrophy at the RV side, causing the double chamber or the obstruction at the RVOT. Isolated DCRV is quite rare, but frequently associated with VSD. As an obstructive lesion, it is progressive in course, so it has a varying degree of obstruction, increasing with time, and this has its implication on the management. The hemodynamic consequences of the obstruction is increasing the pressure in the proximal portion of the RV. Diagnosis and investigation of the double chamber RV, it is clinically resembling the isolated pulmonary valve stenosis. Depends on the degree of the obstruction. The patients may be asymptomatic. Some older children presents with exercise intolerance. In severe forms with proximal high pressure chamber leading to severe tricuspid regurg, and in the presence of an ASD or PFO, it's associated with cyanosis and RV failure. By examination, you have an ejection systolic murmur over the upper left sternal border. When the VSD is present, the clinical features may be dominated by the VSD according to the size of the VSD. So sometimes the patient is diagnosed with a VSD, and you can catch the DCRV presence with the VSD diagnosis. Chest X-ray, mostly normal in mild and moderate cases. but in severe cases, it shows cardiomegaly, right atrial enlargement, and changes related to the VSD. If the VSD is significant, you may find plethoric lung. If the VSD is small, it's still the same feature of the DCRV. ECG is normal also in mild cases. In severe cases, we can see right atrial enlargement, RVH, in the ECG. Still, the echo is a gold standard tool in diagnosis of the double chamber RV. And here we can see an isolated case of DCRV. This is a subcostal view. This is the liver. So we are looking from subcostal view. This is a short axis with left anterior or left anterior oblique view with anterior angulation, showing this is the LV, this is the RV, this is a proximal high pressure chamber, and this is a DCRV. This is a distal low pressure chamber. We can appreciate here the mobility of the pulmonary valve. So this is the anomalous muscle bands. It's far away from the before the infundibulum and the pulmonary valve. And with color interrogation, we can see the aliasing across the obstruction. This another view from subcostal views is a right anterior oblique view. Here we can see this is the tricuspid valve. This is the RV body. This is the double chamber lesion or the anomalous muscle bands. This is the proximal RVOT or low pressure chamber, and here the plane of the pulmonary valve. So we can see clearly in this view the diagnosis and the two. The RV is divided into two chambers. This is the proximal high pressure chamber. This is the distal low pressure chamber. And we are getting the gradient across the stenosis to identify the degree of stenosis like the pulmonary valve. Regarding the management of the double chamber RV, surgical resection is the only or mainstay of intervention. In isolated forms, a mild obstruction with a gradient less than 40 millimeter mercury, like mild pulmonary stenosis, close follow-up because it is progressive. In moderate and severe cases, surgical resection. If it is associated with VSD, surgical resection plus minus VSD closure, and the timing depends on the VSD size and the degree of obstruction. So if you have a large VSD and mild degree of obstruction, you will do it sooner for the sake of VSD and the pulmonary circulation. If you have a small VSD and severe degree of obstruction, so you will do it for the degree of obstruction and by time closing the VSD also. We need to know here, to comment on the, if you're having a severe TR in these cases and estimating the RV systolic pressure is high, and this patient, if associated with a VSD or not, this is doesn't reflect on the pulmonary circulation. Doesn't reflect on the pulmonary artery pressure. So if in a cases of DCRV, if you get a severe tricuspid regurg or tricuspid regurg, that you can estimate the RV systolic pressure. So this RV systolic pressure doesn't equal to the pulmonary pressure because you have still a mechanical or fixed obstruction here. So still the pulmonary circulation is protected by this obstruction. Fortunately, in the cases associated with VSD, also the VSD jet is proximal to this obstruction. So usually the pulmonary circulation is protected by the DCRV. So because we are running out of time, so we are discussing the rest of lesions. As we mentioned, there is a valvular PS, there is subvalvular, infundibular, and supravalvular PS. And the supravalvular includes the main pulmonary artery or branch pulmonary artery stenosis. So the subvalvular pulmonary stenosis or infundibular pulmonary stenosis, this is mostly part of the tetralogy of Fallot or associated with valvular PS, as we mentioned earlier. Sometimes it is dynamic, sometimes it's fixed. It is progressive also. Symptoms and diagnosis similar to DCRV. If you have an isolated infundibular stenosis, which is very rare, depends on the degree of obstruction, the symptoms will be. And this sometimes managed medically with beta blocker, as in moderate cases, or waiting for intervention or surgery, like spills in Fallot or moderate pulmonary stenosis with some infundibular stenosis. Or also sometimes use beta blocker till regression after balloon valvuloplasty, as we mentioned in the infundibular reaction as a complication of balloon valvuloplasty. And managed surgically as part of Fallot repair, or if not, improved after balloon pulmonary valvuloplasty in case of isolated valvular pulmonary stenosis. So this is an example for an infundibular stenosis in a case of Fallot. Again, you should use the echo to identify the level using the pulsed wave Doppler across the RVOT to check where starting the obstruction. So here, this is a subcostal view with left anterior oblique view, shows a dynamic infundibular obstruction in a case of Fallot. And while using the Doppler, we can see the dagger shape pattern, which is characteristic for the mid-cavitary or the infundibular obstructions with late systolic peaking. This is another example of a case of pulmonary valve stenosis with hypertrophy of the infundibular muscle part of the RV. So this is parasternal long axis view with anterior angulation, showing the RVOT and the pulmonary artery. We can see the pulmonary valve here is dooming in systole, and we can appreciate the crowded RVOT muscle bands and the infundibulum. And with the color, we can see the liaising starts below the level of the valve. So here the liaising starts from the RVOT, although there is a valvular pulmonary stenosis also. And now going to the supravalvular pulmonary stenosis, it's very rare. It represents 2 to 3% of the all congenital heart disease. It's frequently seen in syndromic patients like Williams syndrome, DiGeorge syndrome, Alagille, Noonan, and congenital rubella syndrome. It's associated with Fallot and TGA in many cases. And also many cases of supravalvular pulmonary stenosis are acquired post-surgical, like in case of releasing a BA band, sometimes a fibrosis at the site of the band causing supravalvular pulmonary stenosis. In case of TGA, with Lucombe technique at the site of connection of the pulmonary arteries to the main stump, also causing supravalvular pulmonary stenosis, or in cases of RV to be conduits at the site of connections of the branch pulmonary arteries to the conduit. Here, there is a classification. It's an old one, but it's a good one. It's a gay classification. It classifies the supravalvular type of pulmonary stenosis into 4 types. Type 1, when the lesion is single and central. So it's affecting the main pulmonary artery of one of its branches, either the RBA or LBA. And it can be type A, affecting the main pulmonary artery, type B, affecting the branches, maybe short segment or long segment. In the image C here, it's affecting the origin of LBA. In type 2, this is bifurcation stenosis. Either the bifurcation is a short segment of stenosis, pre-bifurcation, or a long segment affecting the bifurcation and the early BA branches. And type 3, this is a peripheral stenosis affecting the segmental arteries. And in type 4, it's affecting the segmental arteries and the main arteries also. So it's affecting the central BAs and the segmental arteries. Clinically, the supravalvular pulmonary stenosis depends also on the degree and the site of obstruction. So when you evaluating a patient with supravalvular pulmonary stenosis, you should look for the dysmorphic features, because as we mentioned, this is commonly associated with syndromic patients. Sometimes it may be asymptomatic with accidental murmur discovered during routine examination, may be discovered during follow-up as a complication after surgery, or in severe forms or bilateral branch pulmonary stenosis in syndromic patients. Also, you can have a patient presenting with RV failure. Diagnosis, initial diagnosis made by echo. This is for the supravalvular at the main pulmonary artery and the origin of the branches, or along the central BAs. But in the peripheral pulmonary arteries, or to identify the lesions in the central PAs, multi-slice CT is the gold standard tool in diagnosis, and especially in branch pulmonary stenosis. Angiography also has a role. It's used for diagnosis in the old days, but nowadays it's used only prior to intervention. I'm giving some hints on the syndromic patients involved in the case of pulmonary stenosis. The Alagille, which is a hepatopulmonary arteriopathy. This patient has dysmorphic feature in the form of prominent forehead, deep-set eyes, pointed chin, and bulbous tip of the nose. The Noonan syndrome, the characteristic feature is the short stature, and some people call it a male Turner. It has an inverted triangle-shaped head, coarse facial features. It has a webbing neck skin and small chin, and also had widely spaced nipples and the cubitus valgus deformity of the upper extremity. Williams syndrome, the Alagille and Noonan, some of them have a degree of mental retardation, but there is some patient with Alagille and Noonan and have a good mental development. Williams syndrome, almost all cases have mental retardation. It's affecting the social, the communication function. They have a chatty party characteristic of these kids while being older. They had some also dysmorphic features. They have a sunken nasal bridge, puffiness around the eyes. They can have low-set ears. They have small and widely spaced teeth, wide mouth, usually have prominent lower lip and small chin. DeGeorge syndrome, and this is one of the Q1122 microdeletion syndromes. The importance of knowing this syndrome, that this patient coming with a small jaw, small upper lip and mouth, and frequently have cleft lip or palate. They have also low set or abnormal folding of the ear. They have short stature and mild to moderate learning difficulties. Knowing them because most of these cases are associated with hypoparathyroid function. Sorry. So they sometimes manifest by hypocalcemia, and also they have underdeveloped thymus. So they have some immune considerations, especially if they underwent surgeries. They need to have irradiated blood or filtered blood to avoid the immune compromisement of these patients. Diagnosing supravalvular pulmonary stenosis and the main pulmonary artery, as we mentioned, it depends mainly on the echo. So this a case of supravalvular pulmonary stenosis, tubular hypoplasia of the main pulmonary artery. This is a parasternal long axis view with anterior angulation. We have seen this is the level of the pulmonary valve, and it is quite mobile, and we have a long segment of hypoplasia in the main pulmonary artery. This patient referred after a balloon valvuloplasty with suboptimal results. So while assessing the patient, we find that the supravalvular area is very narrow. So getting this baby to or this child to cath lab for balloon dilatation is, I mean, is not sufficient and not a good candidate for balloon dilatation. This should go immediately for surgery if the obstruction is severe. And with color interrogation, we can see the same segment of severe narrowing of the main pulmonary artery. So the management is surgical. Another example of membranous type of supravalvular pulmonary stenosis, we can see here the pulmonary valve. Sorry for the poor quality of the image. But sometimes you have at the sinotubular junction a ridge-like or membrane-like type of obstruction in the supravalvular pulmonary stenosis. This type of patient that usually you have a debate about going to cath lab, doing a balloon dilatation first and see the results. And in some of these patients, some people use the medium to high pressure balloons to try to release if there is some fibrotic lesion at the supravalvular area to try to improve the results. So in some cases, it's difficult to identify if it is pure valvular pulmonary stenosis or associated with supravalvular. So you can give a trial for balloon dilatation in such patients. And then if the results is suboptimal or not successful, you can send them for surgery. The gradient also, like the valvular pulmonary stenosis, might be mild with low gradients or maybe severe. In this patient with tubular hyperplasia, the gradient is more than 5 meters or 95 millimeter mercury. Another type of the supravalvular pulmonary stenosis is a branch pulmonary stenosis. The branch pulmonary stenosis can be central or peripheral, as we mentioned. And this is some cases showing the intervention. In most of the cases with branch pulmonary stenosis are catheter-based intervention, especially if they are older children and can we can use balloon dilatation plus minus stenting of this lesion. So this is a baby was 5 years old patient diagnosed as Alagille syndrome, having a murmur by auscultation. So when we get him to the echo, we find a very tight origin LBA stenosis. This is a hypersternal short axis view, identifying the origin of the LBA, and the flow is diminished in the LBA. As we mentioned, CT has a big role in diagnosing these patients. So this is axial cut of the CT showing this is the early takeoff of the LBA with severe kink, although the distal portion of the LBA is of good size. And because of this stenosis, the diffusion, perfusion of this lung is affected. So the RBA is compensatory dilated to accommodate most of the cardiac output. So this is the main pulmonary artery with the RBA. And the intervention in this case was, this is angiography in the LEO projection, shows a short segment of stenosis at the proximal LBA. So we decided to have a balloon dilatation and stenting, and you can appreciate here that the lesion is very resistant to the stenting and the balloon. So we used another balloon to optimize the shape of the stent and to get a good shape of the artery. It's another example of post-surgical complication. This is a baby post-truncus repair. So at the site of this baby had a bilateral branch pulmonary stenosis at the origin. It is at the site of the connection of the BAs to the RV to BA condyle. So this patient presents 6 months or few months after operation with severe RV failure and ascites and low cardiac output syndrome. So admitted to the ICU, and doing the echo, we find that there is a very stenotic long segment at the RBA side and also a stenosis at the LBA side. Doing a CT, we appreciated the identification of the lesion with a 3D volume rendering, shows the short segment obstruction at the LBA and the long segment obstruction at the right side. So getting the baby to the cath lab, and you can see here that the how is the cardiac shadow is markedly dilated with impaired contractility. And we can see in this view that this is a contegra connected to the branch pulmonary arteries, and we can see an origin stenosis of the LBA and the long segment of the RBA. This patient managed with kissing balloon technique using a bilateral balloon dilatation and stenting. And this is the final result. This patient, after 2 or 3 days, was got out from the ICU and can be discharged safely. There's another example of the also post-surgical complication. This patient is an adult patient having a palliative BT shunt on the right side. This BT shunt thrombosed with time. It's done early in age. This patient is not candidate for total repair, so we need to give him some palliative option to improve his lung perfusion and saturation. Because of the most of the flow going to the left lung, so this the pulmonary artery getting a high pressure, which also affecting the strategy for repair. So from the CT, we find that the right side branches are encroached by the BT shunt. So the upper and middle are affected, and also we have a kink at the right lower branch, which still have some flow. In these cases, as a trick, it's better to try to do pulmonary venous wedge injection to try to identify if there is other central or segmental arteries to encroach in this intervention. So I don't have the images here, but we did a pulmonary venous wedge injection in the all pulmonary veins on the right side, and we only find that the only central branches that can that have a forward flow is the right lower branch. So we
would you describe the concept of the wedge injection?
The wedge injection is used in many interventions, even prior to surgery in some cases. So if we have an absent one of the pulmonary artery branches, like in fallow absent pulmonary artery, or not absent valve, I mean absent one of the branches, like absent LBA or absent RBA, and you don't know if you have an artery which is not which is kinked at its origin and not seen because it is not felt. So you can go either from the PFO or ASD to the pulmonary veins and try to wedge with an end-hole catheter or a balloon catheter if you have, and inject in the pulmonary veins and wait for the contrast to go back through the pulmonary vasculature to the arteries. Because in some cases of the fallow or some even isolated cases where absent branch, we find that there is adductal tissue that kink the branch at its origin, and the branch itself is still there, but it's not filled. And when we do the wedge injection, we identify how is the branch developed and how its size, and if we can do some intervention to connect this branch back to the pulmonary artery to recruit this lung and this pulmonary circulation.
So you do that if there is a pulmonary artery, either of one of the two lungs, is not visualized, and you cannot identify its presence by echo or even by CT.
By CT.
And now we're not sure, is that actually an absent artery, or is it just totally disconnected from the circulation, so not even the dye can go through the and detect by the CT? So you go the other way around. So you go into the pulmonary vein all the way till you get wedged, and then when you inject, the only way for the dye to pass is retrogradely to the capillaries and then back into the arteries. And then
Yes.
if it fills an artery, you know that there is an artery there, it's just not visualized. If it is not, then it is a truly absent artery.
Yes.
Thank you.
Also, if you don't have the ASD, some cases, if you have a VSD in fallow, you can go retrograde from the aorta, although it is difficult, but can use a trauma wire, hydrophilic wire to go to the left atrium, and then try to engage the veins with the wire first and further by cath. So you can go through the VSD, through retrograde from the aorta. You can go through the ASD in adult patients with intact septum. You can do septostomy, or even in some young children, you can do septostomy and cross the septum with the catheter and do the wedge injection. So it ends that this case, we only find that the right lower branch can be engaged, and we stented this artery. We know that this artery for a long time not getting a good flow, so its development is affected. So we put a stent that can be dilated further later in life. So to conclude, for the management of the supravalvular pulmonary stenosis, especially the peripheral pulmonic stenosis, the Indian guidelines mentioned that the percutaneous interventional therapy, balloon dilatation plus minus stenting, is a treatment of a choice for focal branch or peripheral pulmonary artery stenosis. With this is the indication with more than 50% diameter narrowing and elevated RV systolic pressure. Although the indication regarding the elevated RV systolic pressure, sometimes in cases when you have an origin LBA stenosis, the RBA, because the right lung has a good volume, sometimes accommodate the cardiac output well without rise of the pressure. So you can back to the indication number 1, which is more than 50% narrowing of the diameter. Or if you have a difference in perfusion of both lungs, more than 20% on lung perfusion scan. And or symptoms, this is a class 1 for intervention percutaneously. Surgical intervention for the above indication, same indication also for surgery, when the stenosis is not anatomically amenable to percutaneous intervention, or if it is in a small baby that you don't have a good profile stents, or the stents that cannot be dilated for an adult size at this age, you can go for surgery for angioplasty. So any questions?
Thank you so much, Mahmoud, for discussing the whole spectrum of the right-sided obstructive lesions, which I really enjoyed. I know you are a bit tired from such a long talk. We have plenty of questions, so I'll pass through them rapidly, and I can help you in answering some of them if you'd like. First question from Dr. Hagar Mustafa about the double-chambered RV and the VSD. She is asking, is the VSD the cause, or it's just an association?
As we mentioned, sorry, Khaled. Are you still?
No, you can go on. Go on.
Okay. So we say that the DCRV have a known etiology, although a lot of theories are implemented in this anomaly. One of them almost both of the theories are including the frequency of association with VSD. So one theory is the arrest of or abnormal incorporation of the bulbous cordus, which is the outlet part that connected to the body of the RV. So during embryological life, the bulbous cordus, this is the part that involves the infundibulum, and it is connected to the RV body. And this part also the part that closes the membranous septum, so its deficiency or its improper incorporation lead to a perimembranous VSD. So it might be associated with a VSD as a part of embryology due to improper incorporation of the bulbous cordus or the infundibular part to the body of the RV. Or the other theory is that the jet of the VSD, and we have seen a lot of cases that with RCC prolapse in the VSD with the jet to the other side, leading to hypertrophy at this part, causing obstruction. And some people call it as a syndrome of VSD and RCC prolapse with the RVOT obstruction. And Prof. Yaqub has a very nice paper discussing this, morphology of this syndrome. So it may be a result of the VSD jet, and this in this situation, you will catch the VSD first, and you will see with a follow-up if the VSD is restrictive that there is hypertrophy occurring at this site. If it is due to coincidence due to improper incorporation of the bulbous cordus to the body of the RV, so it may be associated embryologically as a part of the problem itself, not a cause-result relation.
Okay, so to sum up, both are applicable, both theories are applicable, whether it is an association between the VSD and the double-chambered RV, or the other theory that the restrictive VSD flow itself could result in an progression of irritation of the RV wall, resulting in double-chambered RV.
Yes. Yes.
Okay. Another question: can we have a pulmonary hypertension in the presence of pulmonary stenosis?
Yes, sure. As we mentioned early, we have seen a lot of neonates in the NICU presenting with severe pulmonary hypertension, and we see a large ductus, and we cannot see any gradient across the pulmonary valve. Although by 2D we can see that the valve looks thickened or have some restricted mobility, but sometimes we relate this to the severe pulmonary hypertension because we have we have a large BDA and severe pulmonary hypertension. So in these babies, you advise if they are preterm babies, you are advised for medical closure of the BDA or fluid restrictions and diuresis. And when this baby gets out of the NICU, we have seen some of them presenting at the clinic with ejection systolic murmur, and we found that there is a valvular pulmonary stenosis after regression of the neonatal pulmonary vascular resistance and the closure of the BDA or restriction of the BDA. We started to see severe PS in many cases with the same scenario. This is one scenario. The other scenario, as we mentioned, that you may have in syndromic patient specifically a peripheral or segmental artery obstruction in different level, or even the whole pulmonary vascular bed is hypoplastic, and so you have a distal hypertension to the pulmonary valve. So you may have a valve stenosis with a low gradient, although the morphology of the valve is highly suspecting that this is a valvular pulmonary stenosis. You have thickened pulmonary valve, you have a dooming pulmonary valve, and you don't have a gradient across the RVOT. It's maybe due to distal hypertension because of the distal obstruction, or maybe due to RV impaired function, as Khalid mentioned before, in the low gradient pulmonary stenosis.
Okay. Would you please allow me to rephrase your words because we want the message to be clear. presence of pulmonary hypertension is obsolete in the presence of pulmonary stenosis. Both couldn't combine ever except in two situations which you mentioned. In neonates who have either persistent pulmonary hypertension or large PDA causing elevated pulmonary artery pressure, and in the presence of peripheral PS, although in the presence of a peripheral PS, we have a protected lungs. Pulmonary hypertension and pulmonary stenosis couldn't mix. Okay, am I right?
Yes, yes, Khalid. This are we talking on the isolated valvular pulmonary stenosis because there is a lot of lesions with valvular pulmonary stenosis mixed with a VSD or mixed with another lesions that may causing increased flow, pulmonary hypertension, or whatever. But we are talking here about the isolated valvular pulmonary stenosis.
Okay. We have another question from Dr. Ahmed Al-Nahas. And if I'm not wrong, can we do a transcatheter pulmonary valve implantation in the same session to protect babies from free pulmonary regurg after balloon valvuloplasty?
It's a nice question from Ahmed, but I mean, we are talking about babies, maybe
yes.
3 kilograms,
neonates,
maybe a child with 10 to 15 kilogram. So, and also we should have the criteria of indication for pulmonary valve replacement. It's a different mode of management for a different scenario. If you do have severe pulmonary regurg after ballooning a dysplastic pulmonary valve, you should follow the patient till you collecting the criteria for valve replacement, whether surgical or transcutaneous, depends on the age of the patient and the profile of the valve available. So the pulmonary incompetence, it's another story. And having a pulmonary incompetence after balloon valvuloplasty is not, it's well tolerated for a long time, not as such findings that needs to be managed. So having a pulmonary incompetence as such is not an indication for pulmonary valve replacement. You should fulfill a criteria which is well established in the guidelines, almost simulating the criteria of valve replacement after fallow repair with transannular patch, the same criteria used for both types.
So if we
and I think that the option in this case, if you have a severe pulmonary regurgitation with an indication for pulmonary valve replacement, the option would be surgical. I think up to date, transcatheter pulmonary valve implantation is preserved for adolescents.
So if you calculate from the cohort of the fallow repair, which is obviously a big and long experience with surgery, people have always wanted to leave patients with competent pulmonary valves. So it was found that free pulmonary regurg after transannular patch with tetralogy of fallow is actually very well tolerated for years. It does make the post-operative course more difficult, but on the other hand, on the long term, it is very well tolerated. On the other hand, the patients who had implanted valves while they were very young, and this is actually also evident in the cohort of the truncus arteriosus. Putting valves in very young baby requires a lot of reoperations. So patients quickly outgrow the size of the valve. And
regeneration then also of the valve.
Yes, because the valve will not grow. And on the other hand, as you say, when the valve degenerates, it actually mostly degenerates in stenosis. So the baby grows older while the valve actually gets smaller. And in contrast to the pulmonary regurg, on the other hand, the pulmonary stenosis, severe pulmonary stenosis is not well tolerated and can really affect the ventricle and the clinical condition of the patients. So on balance, I believe leaving the patients with, obviously trying to avoid in the, as much pulmonary regurg as possible is the way to go. So in the fallow repair, we try very hard to preserve pulmonary valve function as much as possible. But as you say, with the balloon, you try as much as possible also to avoid getting regurg. But this should not push us to the extreme of putting valves in very small babies, because the reoperation rate here will be much higher.
Okay.
Okay. Another question from Dr. Haitem Sukkari about the rule of TE and 3D echo for double-chambered RB and other right obstructive lesions.
Yeah, we have the problems with the 3D TE, 3D echo in the small babies because of the heart rate and the respiration, and you need to get the patient under anesthesia to get a good images. While we have in the small babies, we can get a good images with the transthoracic echo. So rarely we need to use the TE as such, unless you have an adolescent patient or adult patient with poor winds, or you need to identify more details about the valve if it is entangled in these muscle bands or something like that. This is my experience. I don't know.
If you allowed me to answer this question also.
Please, Khalid.
Pulmonary artery is the most anterior structure in the heart, so it is easily to get good windows from transthoracic echo than getting the windows from the TE or TE 3D, because the pulmonary artery and RB is the most anterior structure. So it's very easy to get proper windows by transthoracic echo.
Yes, I agree.
Okay. Another question from Dr. Ahmed Fouad about the use of how frequent can we do a balloon pulmonary for valvular pulmonary stenosis?
How frequent regarding the recurrence?
Regarding the recurrence.
There is some incidence of recurrence of valvular pulmonary stenosis post balloon dilatation, around 10 to 25% in some studies. This depends also on the results of the first balloon dilatation, and also biased by some cases which have element of supravalvular that's done multiple times without a good results. So you can have an incidence of recurrence. This is one of the complications after balloon dilatation, especially in the dysplastic valves and the thickened valves with a critical pulmonary stenosis. You initially dilate, getting the baby in a better shape, and then some of these babies needs further balloon dilatation. So you can do it. I couldn't say as much as you can unless you have an evidence.
Unless you have an evidence.
Yeah.
I was expecting this answer. I have a question for you to simplify it. You, Mahmoud, in your experience, how often did you see a recurrence for pure valvular pulmonary stenosis whom you dilate by yourself?
I think I see like, you mean more than one time, you mean? Because
more than one time.
Yes.
More than one time.
More than one time, as very few cases we have seen with either they are balloon dilated with suboptimal results from the first time, because sometimes you do have the near size balloon, but the valve was dysplastic and you need a medium pressure balloon, which is not available at the first time. So you are getting out with the suboptimal results, but accepted. And then wait till the baby develop further gradient again and get him and do the adequate balloon valvuloplasty. In my experience, I have seen people balloon dilated for the second time. This is quite common in most of the interventions. But for twice for the same patient after the first balloon dilatation is very few. usually there is another element that cannot be solved with a balloon, and you need to refer for further intervention.
I think this is the reason. I think probably the most important thing here is to define that it is really valvular pulmonary stenosis, because as we've just mentioned, sometimes it is difficult to delineate, is it a true valvular or is it supra or subvalvular? We know that true valvular responds very well to the balloon. On the other hand, the sub and supravalvular does not. So having a suboptimal result, is it a technical thing, as Mahmoud said, or is it a recurrence, which can happen obviously, or on the other hand, is it a suboptimal result because the problem is not the valve itself, it is just above or just below? So this is the wise thing here to.
If you have a baby coming for the third pulmonary valvuloplasty, you should have all your doubt to identify why it's not solved in the first 2 times, because most of the patient is resolved after the second balloon valvuloplasty. But having a third balloon valvuloplasty for the same patient, you should suspect another cause of the obstruction, which is not addressed in the first 2 times.
And it's very rare to see a recurrence in a purely valvular pulmonary stenosis who was properly dilated.
Yes. I mean, having a baby, I mean, our child with a balloon dilatation and a gradient of 20-30 after balloon dilatation, it's very rare to develop valvular pulmonary stenosis again. And some studies about the natural history for the patients of moderate pulmonary stenosis and balloon dilated shows the same course like the mild valvular pulmonary stenosis from the start.
Okay. And I think this is what we mentioned in one of the cases, that if you have a very high pressure gradient like 110 or 120, the success of procedure is getting with a pressure that is 50% of the original, so you can go out with an 50 or 60 millimeter mercury pressure gradient across the pulmonary valve, and those who undergo another session for balloon dilatation.
Yes.
An interesting question from Dr. Ahmed Nahas also. He noticed more than one case following dilatation of critical PS who had problem post-intervention of LV dysfunction rather than RV problems that we've discussed. Do you have an explanation for that?
You mean early post-intervention or later on?
Early post.
Early. As we mentioned in the critical PS, if you do have BDA dependent pulmonary circulation, so this LV is compressed by the markedly hypertrophied RV, so it has a pressure overload from the interventricular dependence from the RV side, and has a volume overload from the BDA, which sometimes we need the prostaglandins to continue for a while. So having the volume overload and the pressure overload in this LV sometimes ends with an LV dysfunction. This is my explanation.
And probably if the cardiac output markedly increased after opening the pulmonary valve, actually this might be a lot more volume load than the LV is used to see. Or if the RV is still very dysfunctional, a lot of blood will be passing through the PFO into the left side, and keeping the PDA open is also not helping. So volume load on previously unloaded LV.
Yes.
I think we are
running out of time.
I think no, but I think we are done for today.
I think so.
We don't have any more questions. I would like to thank you so much, Mahmoud, for your elegant presentation, and I would like also
Khalid, I'm sorry, just one sentence about the pulmonary atresia intact septum, because it's one of the lesions that will be discussed later, but to end the presentation. I'm sorry, Khalid.
Sure, go on.
The last this last obstructive lesions will not be discussed in details, the entity of pulmonary atresia, especially with intact septum. We have pulmonary atresia with VSD, and those are managed like fallot, and pulmonary atresia with intact septum, and these cases need further discussion, but they in the good cases of this type, they are managed with perforation of the pulmonary valve and balloon dilatation. But keep in your mind that the first thing you should think about when you are facing the pulmonary atresia lesion, you should maintain the adequacy of the cardiac output and the pulmonary circulation. So if you have pulmonary atresia VSD, you should be sure that the BDA is adequate to maintain the circulation, as the cardiac output is maintained through the VSD. And in case of pulmonary atresia intact septum, you need to be sure that the ASD is sufficient to maintain the cardiac output, and the BDA is adequate for pulmonary circulation. These are the simple things that you need to keep in mind facing a case of pulmonary atresia. Maintain the adequate cardiac output, either through the ASD, or be sure that there is a VSD, or maintain the pulmonary circulation through the BDA, and then further investigations are needed to address these anomalies. Thank you so much. This our talk for tonight.
Thank you very much, Mahmoud. Very nice talk.
Thank you so much, Mahmoud.
Thank you so much, Mahmoud. Thank you so much, Khalid Shams. Thank you so much, Hatem Hosni. You did a great job today. This was an excellent webinar regarding tackling this issue with all the types of right-sided obstructive lesions in the form of interesting case-based discussions. And of course, I would like to thank Mahmoud Shahata for preparing this big and important lecture and streaming it very nicely and smoothly to convey the scientific data in the form of very elegant discussions moderated by Khalid Shams and Hatem Hosni. Thank you everyone that watched us on the YouTube and on the Zoom, and thanks to everyone at the Congenital Heart Disease. Just an announcement for next Saturday, starting from next Saturday, July 11, we will shift 30 minutes, so it's going to be 9:30 instead of 9. For Tuesdays and Thursdays, the regular is 9 p.m. until we announce something else. Next Saturday in the Congenital Heart Disease course, a very interesting topic, physiology of fallot, will be discussed probably with lots of imaging and lots of surgical interventions. So stay tuned. This is a nice webinar. I would like to attend in person. Next Tuesday in the intervention course, we are having the bifurcation campus. We will be discussing the T techniques and the TAP techniques, of course, with Dr. Hisham Ammar from the National Heart Institute and Dr. Ahmed Saeed from the Shminikum Teaching Hospital. This is one webinar also not to miss. And the big surprise is next Thursday. We will be presenting for you a very interesting issue, unusual STEMI presentations. It will involve clinical and angiographic cases for unusual presentations for different patients presented by STEMI. The CEC board will be speakers, and Professor Karim Saeed from Cairo University will be moderating with us this session. This is going to be a landmark session, I promise you. So thank you all for attending with us tonight, and hopefully we can see you next Tuesday, inshallah. Bye-bye.
Thank you so much.